We are live.
Good evening and welcome to the 17th module of Neuro-ophthalmology. And we are starting the MasterClass series from today. And today we have a recorded class from one of the best known teachers in neuro-ophthalmology, Dr. Andrew Lee. He joins us from Houston Methodist in Texas. He has numerous publications, numerous book chapters. He got trained under one of the doyens of neuro-ophthalmology, Dr. Neil Miller, and now he has trained quite a few fellows who are doing themselves very well. And he's a fantastic orator and a great teacher. So unfortunately, he has some work now, and so he was kind enough to send a recorded version of his talk, which we'll be playing now. Over to you, Asha, for Dr. Endigi's lecture.
Yeah, thank you, sir. So I'll be sharing the recorded version. So whoever have the questions, you can share them on the portals, YouTube and Facebook. We'll be answering after the session.
Hi, my name's Andy Lee, and I'm going to be talking to you about optic neuritis, some things you don't know about something you know well. I want to thank the organizers for inviting me today. In 1978, I wanted to be a doctor. My second choice was Jedi Knight. You can see me here, quite short than my peers, who are much taller than I am. And this was my teacher. And be the mentor that you needed when you were young. And Mr. Dorr here was a mentor to me. And I never really got to thank Mr. Dorr for this because he died on the class field trip. But I remember how inspirational he was to a young person of an impressionable mind going into science. I wanted to go into space. I wanted to have a Jedi superpower and use the Force, and I wanted to be a doctor. It turns out that superpowers are real, and the power to detect disease and death by looking in people's eyes is a real power, a real Jedi superpower. And the Force is used to deflect the Reaper. So a lot of what I'm going to be talking to you about is deflecting the Reaper. And even though I have no financial interest in the contents of this talk, I have a definite interest in you and your patients. And one of the things I hope you'll take away from this is, with this great power comes great responsibility. Your great responsibility is to be a doctor first, an ophthalmologist second, and a vitreoretinal surgeon or a cataract surgeon third, in that order. So here's what I'm going to be covering for you in the next 20 minutes. The typical optic neuritis, the results of the typical optic neuritis treatment trial, and some things you may not know, which is neuromyelitis optica, which is aquaporin 4 antibody-mediated optic neuropathy, and myelin oligodendrocytic glycoprotein MOG antibodies. And having a normal MRI might be good because you don't have multiple sclerosis, but it might be bad. And in those cases, I order both the NMO and the MOG. And we have to ask some seriously weird questions about patients with optic neuritis that we didn't have to ask before. My dad would say, if it looks like a duck and quacks like a duck and flies like a duck, then it's probably a duck. So you need to be able to know what your duck looks like. So in the Western world of medicine, this is what it looks like. A 20-year-old white female with acute unilateral loss of vision, in this case to 20/40 vision in the right eye. She has a mild relative central scotoma on automated perimetry. She has a normal left eye. She has pain with eye movement, an RAPD, and a normal fundus. So this would be what typical optic neuritis looks like in the United States. And the optic neuritis treatment trial is based on that. So one of the caveats that I would leave you with is optic neuritis in different parts of the world, for example, India, it looks different. It tends to be more bilateral. Your optic neuritis tends to be more infectious, including tuberculosis, and you have a lot more disc edema. So you definitely have to do some things different than just the typical optic neuritis treatment trial. And I'm sure during the Q&A, we'll have time to talk about that some more. The optic neuritis treatment trial, however, in the United States for typical Western optic neuritis was a randomized controlled clinical trial of intravenous steroids versus oral steroids versus placebo. And in that trial, no laboratory studies actually helped, even though they did ANAs and syphilis serologies and things. However, in your part of the world, I think it is worthwhile to test for the infectious etiologies, including making sure it's not tuberculosis. A lumbar puncture didn't add anything except for demyelinating disease. They were looking for oligoclonal bands, and visual evoked potentials really didn't help at all if they had clinical optic neuropathy. And in the optic neuritis treatment trial, you can see the three arms: methylprednisolone, intravenous, placebo, and oral prednisone. All the groups recovered, but the slope of this line, the intravenous steroid group, got better quicker. And so the cumulative rates of recovery of normal visual field in the first 6 months was equivalent, but you just get better quicker. And if you look at visual acuity, it's the same kind of data. All three arms, methylprednisolone, placebo, and prednisone get better, but intravenous steroids get better quicker. And so we use the intravenous steroids to get people better quicker. One of the unexpected things that was seen in the optic neuritis treatment trial was the patients that received oral prednisone alone had a higher rate of recurrent optic neuritis compared with either intravenous or placebo. So in this trial, you would have been better off receiving the placebo than the oral prednisone because it increased the rate of attack. You can see 41% versus 25% in the intravenous and placebo arm. There are a number of hypotheses for why that occurred. Probably it's a dose-related effect, however, because intravenous methylprednisolone is not the same as 60 milligrams oral prednisone. The conclusion of the study, however, was that standard dosing of oral prednisone was not only not indicated in typical optic neuritis, it actually might make people worse because of the risk of recurrent optic neuritis. And if you look at the cumulative probability of clinical definite MS by treatment group in the first 2 years, here's the intravenous arm versus placebo and prednisone. And what you can see is within the first 2 years, the risk of developing clinical definite MS was less in the intravenous arm. Over time, that effect wore off. So we don't use this per se for a treatment indication, but you should know that it probably does have a longer lasting effect than just the immediate recovery of the vision. The test in the trial was not an MRI with contrast, it was just a T2 MRI, but now we do both fat suppression and orbital MRIs to look for this enhancement. And the typical enhancement on a fat suppressed T1 post-contrast study is a small short segment of orbital enhancement. You need to have fat suppression because the fat will cause volume averaging. You won't be able to see the nerve very well. So this is no fat suppression and this is fat suppression. So with the fat suppression, the fat is not as bright because it's been suppressed, and the T1 MRI can show the gadolinium enhancement. And that's really important because most cases, I would say over 90% of cases, as in this Cooper-Smith paper from Brain, have some type of enhancement. So you can see the number of people that have zero enhancement is less than 5%. The vast majority have short segments of enhancement. And so if there's no enhancement, that's a big red flag that maybe it's another diagnosis. So that's a typical duck, a typical optic neuritis in the Western world. If it walks like a duck and swims like a duck and quacks like a duck, well, you know. And so you should beware when the radiograph or the clinical finding doesn't match. So if it's an older patient, or if it's bilateral, or if there's severe pain, or even if there's no pain, and if there's disc edema, these are big red flags that maybe it's not typical demyelinating optic neuritis. And in your part of the world, that's infectious optic neuritis you have to worry about, in addition to the antibody-mediated optic neuritis, MOG and NMO. And so when we're looking for the enhancement, if we have long segment or bilateral segment or chiasmal enhancement, these are big red flags that maybe this is a typical optic neuritis. And one of the interesting things is, as you know, the optic nerve has no pain fiber. And so when they have no pain, often it's the intracranial segment that is enhancing because it's the pain without movement is caused by the trigeminal, which is pulling on the sheath when they move their eyes. So intracranial enhancement that's bilateral or longitudinally extensive should suggest to you that maybe this isn't demyelinating optic neuritis. The other thing that should worry you is if the nerve is big. So if it's a long segment or enhancing a lot or nodular, or if it's enlarged or bilateral, that's a big red flag that maybe it's not demyelinating optic neuritis. So here's another radiographic feature that you should be worried about if the enhancement goes out into the sheath or into the fat. This is actually suggestive of perineuritis around the nerve rather than just the parenchyma of the nerve. And you got to be thinking about sarcoidosis as well as MOG, myelin oligodendrocytic glycoprotein in these cases. So if the enhancement goes outside of the nerve itself, that's also something to worry about. We use FLAIR, fluid attenuation inversion recovery, to look at the white matter in these patients. We're looking for demyelinating periventricular juxtacortical white matter lesions. that may or may not enhance if they're active. And so it suppresses the normal CSF signal and allows us to see pathologic white matter. So here on the left, you can see the normal T2. The CSF is very bright. So it's like the T1 study in the sense that fat is very bright. We want to suppress that fat on fat suppression on T1. On T2, we're suppressing it with a fluid attenuation inversion recovery sequence called FLAIR, and it shows the periventricular ovoid white matter lesions better. So there's some things that you should say that's not quacking like a duck. So these things over here are not ducks. So one of the paradoxical things is if the nerve isn't enhancing. So I told you that in the Cooper-Smith paper, most of the cases had some degree of enhancement. If it's not enhancing, that's really not quacking like a duck. And if there's no white matter lesions seen on the brain MRI, that's good because it's less likely to be multiple sclerosis. But it's also bad because if it's less likely to build multiple sclerosis, it's more likely to be one of those other things like MOG or NMO. So it still could be a monophasic, one and done optic neuritis not related to MS with a normal MRI, but it could also be NMO or MOG. And so these are the different ducts that you need to worry about, which is NMO and MOG. It superficially looks like optic neuritis from MS, but you have to order the test to differentiate these. NMO, neuromyelitis optica, affects women disproportionately, and in our part of the world, it's going to be people of color. That's African Americans and Asians, and probably the same thing is true in your part of the world, where multiple sclerosis is a lot less likely. NMO and MOG probably are going to be higher on your list. The Asian form, including Indian subcontinent of multiple sclerosis, often looks like neuromyelitis optica, which we used to call Devick's disease. And most NMO patients are actually initially misdiagnosed as MS. So if you look at the worldwide incidence of multiple sclerosis, it tends to occur in the same latitudes in the northern hemisphere and in the southern hemisphere. You can see the higher red and orange range are in the northern hemisphere, Canada, America, and Europe, and in the southern hemisphere, Argentina, nothing in Africa, but South Africa, Australia, and New Zealand. Notice that India and these middle places are way less likely to have multiple sclerosis. And it tends to correlate with wine production. I'm only slightly kidding here, but probably the weather is what's determining that, the latitude and your sun exposure. It's not actually clear what causes this. So if you've got good wine, you probably have MS. So that's Napa Valley and French wines, and then the Australian Shiraz, New Zealand Sauvignon Blanc, South African Chenin Blanc, Argentinian Malbec, and Chilean white wines. So if you look at NMO, it's kind of the opposite. NMO has a global distribution, but we have way more people who are Afro-Caribbean descent. You can see the 10x number here compared with the MS and the NMO in the United States, and probably Indian subcontinent is somewhere in between. So neuromyelitis optica, NMO, is characterized by optic neuritis, that's the NO, and the myelitis. They don't have to occur at the same time. They're often separated in time and space, just like MS. But the key and differentiating features are there are no demyelinating white matter lesions that are typical for MS. It tends to be bilateral or rapidly sequential or even simultaneous optic neuropathy. It tends not to get better. It's not as steroid responsive as MOG or demyelinating MS-related optic neuritis. The transverse myelitis is over 3 longitudinal segments, so 3 vertebral segments. So it's longitudinally extensive transverse myelitis and longitudinally extensive optic neuritis. And as I mentioned, it tends not to recover. It's bilateral, and the brain MRI tends to show features that are not typical for MS. In addition, a CSF pleocytosis of greater than 50 white cells and negative oligoclonal bands also should tip you off that it might be NMO. So here's a typical optic neuritis unilateral, short intraorbital section of enhancement on the post-contrast fat suppressed T1 versus bilateral, longitudinally extensive, or chiasmal involvement in NMO. And NMO and MOG are both antibody mediated. You can see the MOG antibody here is directed against the target myelin oligodendrocytic glycoprotein. And with NMO, you have the additional factor of astrocytic damage induced by activation of complement. And so MOG tends to have a better prognosis and is more steroid responsive than NMO, which is a much more aggressive and destructive process. And even a single episode of transverse myelitis or optic neuritis can be potentially debilitating with high morbidity and potential mortality. The aquaporin 4 rich areas produce very strange symptoms. And so if you took a green magic marker and you just drew around the aquaporin 4 rich areas on this sagittal, you can see it starts in the chiasm, which is accounting for the bilateral optic neuritis, hypothalamus, which can produce symptomatic narcolepsy. And then we're going to trace our way around the aquaporin 4 rich areas and get down here to the area postrema, where we have to ask about vomit center questions like intractable hiccups and unexplained nausea and vomiting. So these are the seriously weird questions you have to ask all patients with optic neuritis: intractable hiccups, unexplained nausea and vomiting, and narcolepsy. And if you look at myelin oligodendrocytic glycoprotein, it has an even wider spectrum of disorders that you have to be thinking about, including childhood acute disseminated encephalomyelitis, ADEM. It can look like seronegative NMO, so it's negative for the NMO antibody, and have optic neuritis and transverse myelitis. It is neuromyelitis optica, but the MOG antibody instead of the aquaporin 4 antibodies positive. Short and long segments of transverse myelitis, including longitudinally extensive transverse myelitis, that is the radiographic feature of NMO, bilateral optic neuritis, and even unilateral optic neuritis. And so the spectrum of MOG is so wide that unless it's clearly typical multiple sclerosis on the MRI, we're pretty much ordering the MOG on these people. And one of the things that's a characteristic feature on the T1 post-contrast fat suppressed image is the enhancement of the sheath, and the enhancement can go out into the fat. So those are tip-offs that it might be MOG. The MOG antibody and the NMO antibody should be ordered in atypical optic neuritis. And atypical to means it's not quacking like a duck, non-recovering, they don't get their vision back. Only about 3% of optic neuritis from demyelinating disease or idiopathic is 2200 or worse. Bilateral, simultaneous, or sequential optic neuritis, or if it's involving the sheath or the fat, that's the perineuritis. If we have recurrent optic neuritis and the brain MRI is not typical for MS, that's also a suggestive feature that it might be MOG. And atypical white matter disease or CSF pleocytosis greater than 50 white cells with negative oligoclonal bands. The transverse myelitis is a gimme. You should definitely test for NMO and transverse myelitis, and you need to ask about these seriously weird questions: nausea, vomiting, hiccups, which is area postrema, and symptomatic narcolepsy from the aquaporin 4 rich areas in the hypothalamus. So our current practice is, if you have a longitudinally extensive spine lesion, or you have longitudinally extensive optic nerve enhancement, or multiple attacks of optic nerve involvement, we're definitely going to order the NMO and probably going to order MOG as well. In a single episode of optic neuritis, you could order it. It's probably not required. If they have MS-related findings, I don't order it. But if they don't, you could order it. And short spinal cord lesion, we probably should order that too. In the acute setting, it doesn't matter because both for optic neuritis, typical MS, MOG, and NMO, everybody's going to get intravenous methylprednisolone. And if they have minimal response, we're going to switch to plasma exchange or rituximab. Normally, we don't wait for the antibody to come back if it's clearly NMO or MOG clinically or radiographically. And if you look at this dotted line, which is negative for NMO versus the solid red line, positive for NMO, cumulative survival in this Kaplan-Meier curve, time over months, the chance of you getting a transverse myelitis event, which is this solid blue, is 40% by 10 months. And an optic neuritis event, 50% by 10 months. So if we don't treat at time 0 with some sort of treatment, they're going to get something else, usually recurrent transverse myelitis or optic neuritis. So we're seeing the people at time 0. That's your chance to make the diagnosis. Again, if you look at NMO seropositive against NMO seronegative, and the percentage of people who get transverse myelitis from time of onset in years, the vast majority of these NMO seropositive people are going to get myelitis. And so that's why it's important to recognize the disease at time 0 when you're seeing them with just the optic neuritis before the myelitis event occurs. And so in summary, for optic neuritis, some things you know well. You probably know the optic neuritis treatment trial. You probably know what typical optic neuritis is. You know what that duck quacks like in the United States: acute unilateral loss of vision in a young person, pain with eye movement, retrobulbar, and just gets better whether you give it steroids or not. We don't give oral steroids, however, in conventional doses to our typical optic neuritis, and we're looking for demyelinating white matter lesions on MRI, including flare and enhancement on T1 post-contrast gadolinium-enhanced MRI. However, in your part of the world, you got to think about infectious etiologies. It's more likely to be bilateral, it's more likely to have disc edema, and it's less likely to be multiple sclerosis. And therefore, some things you don't know, you probably should be testing more for NMO and for MOG, especially if there's the radiographic feature of enhancement of the sheath, or if it's markedly steroid responsive, or if it doesn't have the typical demyelinating white matter lesions. In this setting, having a normal MRI scan might be bad, it might be good. It's good because you don't have MS, it's bad because you don't have MS, and therefore we're gonna order the NMO and MOG in all of those circumstances. And don't forget to ask those super weird questions about aquaporin 4-rich areas, intractable nausea and vomiting, intractable hiccups, or symptomatic narcolepsy. And I thank you for your time and attention.
So that's an excellent talk, as usual, by Dr. Lee. So now I will be inviting Dr. Gunjan to discuss the rest of the cases. So the rest of the cases, as we have heard a lot now about optic neuritis, especially the atypical ones, the new year improvements. So we'll be giving a few case scenarios in which we will be able to discuss. Dr. Gunjan is a senior resident who is working currently in Neuro-ophthalmology and squint department from Dr. R.P. Center, AIIMS, New Delhi. And Dr. Gunjan, you can go ahead. And we have Dr. Praveen as our hot seat. So you can make it interactive by asking him the case scenario. Yeah, over to Dr. Gunjan.
Thank you, Dr. Asha, for the kind introduction. So now I'll be sharing my screen and we'll be discussing our questions. I'll be sharing some of the case scenarios. Yeah. So this is our first case. The first case is of a 32-year-old male patient who presented to us with complaints of sudden onset blurring of vision, which was associated with headache since last 7 days. Moreover, there was no similar family history. Patient also had a history of blurring of vision, which was present during evening hours, noted since past several years. There was no history of recent episode of fever or tuberculosis or any other systemic illness, and there were no similar episodes in the past. So on examination, patient's visual acuity in the right eye was 660 and in the left eye was 636. Pupils were sluggishly reacting in both the eyes. And on fundus examination, there was generalized attenuation of blood vessels with bony spicules in the periphery. But besides this, in the disc, there was also a blurring of disc margins. The disc appeared to be elevated from the surrounding with there were disc hemorrhages, there were macular edema and exudates. I'll just show the figure. So this is how the fundus of that patient looked. And this is the ultra-wide field imaging of that patient. So I would like to ask Dr. Praveen, what could be the possible diagnosis based on this clinical examination?
Ma'am, probably it could be retinitis pigmentosa.
Yes, it is retinitis pigmentosa, but along with that, we can also see that the patient also has some other features of disc edema and
Yeah, ma'am, there is a means disc edema. We can see peripapillary means hemorrhages, means flame-shaped hemorrhages.
Yeah, and in the macula also one can see that there are the macula.
Actually, ma'am, I cannot appreciate the image. Macula, there is a means
Clear image. You will be able to appreciate if you look closely. There's a macular star. There are macular.
Yeah, ma'am. There is a means scarring over the macula area.
It's not a scarring. It's a macular star. Along with that, there are exudates surrounding the macula.
Right, ma'am. Right.
There's no macular scar as such in this patient. So we advised further investigation to the patient, which included color vision and contrast. These were reduced. Visual field showed a generalized depression, and visual evoked response showed an equal visual evoked response in both the eyes. However, the latency was same, amplitude was reduced. And we also advised contrast enhanced magnetic resonance imaging, which showed multiple hyperintense lesions in the periventricular region, and other infectious etiologies were also ruled out. ESR and CRP were normal. Now my question will be, what could be the possible diagnosis based on these investigations and the fundus picture?
Ma'am, it could be infectious cause of optic neuritis.
But we had already ruled out other infectious etiologies,
Okay.
and ESR and CRP were also normal. And you can see something in the MRI also if you look closely. And moreover, the patient also had hemorrhages along with the disc edema and macular star, which was also there.
So
So
it's neuroretinitis.
now I have shown you this. Yeah, the main two differential diagnosis in such a case with macular star, blood disc and hemorrhages could either be neuroretinitis or hypertensive retinopathy. These are the two differentials in this case.
Right, ma'am.
But see, neuroretinitis usually has a unilateral macular star. And in this case, because the blood investigations were within normal limits, infectious etiologies which were also ruled out, so neuroretinitis was unlikely. However, in a patient who is having a bilateral macular star, one should always raise a suspicion of hypertensive retinopathy. And in this patient, the blood pressure measured, which was high on the higher side, it was 220 by 130 mmHg, and renal function test also were deranged. So,
Right, ma'am.
patient was a case of hypertensive retinopathy with retinitis pigmentosa. Okay,
Thank you, ma'am.
so that is what I explained to you just now. There are certain case reports which have also emphasized on this fact, and that's a general rule that if it's a bilateral macular star, it's more likely to be with papilledema, it's more likely to be a grade 5 hypertensive retinopathy. So now moving on to our next case, which is you can see that eyes as the key to the Pandora's box, and we'll later come to know why I have labeled it so. So this case is of a 4-year-old child who presented with sudden onset blurring of vision since past 4 days. Along with that, he had a history of fever, which was on and off since 4 days. There was no history of recent vaccination or weight loss, and there was no other significant systemic history also. General examination and neurological examination were within normal limits. Now, this is the ocular examination. The child was not fixing. Pupil were fixed at 3 mm. Bilateral ocular movements showed mild limitation of abduction on the right side. And I'll just show you the fundus picture. You can see that the disc is hyperemic with blurred margins. And in the left eye, you can see that there is temporal disc pallors with blurred margin.
Right, ma'am.
So I would like to ask you, what would be the differential diagnosis based on this clinical examination?
Could be, ma'am,
So you have,
retrobulbar
continue.
retrobulbar optic neuritis.
See, in
Since
retrobulbar optic neuritis, I think you won't be able to see this blurred disc margins also in most of our cases. So yes, there is a disc edema. There's a disc edema in one side, and you can see that there is a disc pallor on the other side.
it is papillitis.
Yeah, it is papillitis, and the other side there is a disc pallor, which is a disc atrophy. Okay.
Right, ma'am.
So what would be the differential diagnosis based on this clinical examination? anything like this, when it comes to you, like one eye disc edema and other eye disc pallor, it could be a sequelae of bilateral papillitis, like demyelinating lesions, which could be NMO or MOG positive, or it could be infectious lesions, or it could be a sequelae of increased intracranial tension, or any other space occupying lesion. Okay, so in
Right.
most of our optic pathologies in neuro-ophthalmology, you can easily classify them either as congenital, inflammatory, which could be either autoimmune or infectious etiology, trauma, toxic, or tumors. Okay, and ischemic causes in adults, definitely. Okay, so
Right.
the possible things which could be there in such a scenario. Okay, so we advise CMRI, brain and orbit in this patient, which showed the presence of mass lesion with inflammation, which was extending from the orbital apex to the cavernous sinus and was compressing the right optic nerve. So based on this, I would like to ask you, what could be the differential diagnosis of a lesion at the orbital apex?
It could be retinoblastoma.
Retinoblastoma will have some intraocular tumor also, which is not there in this patient. You can see the globe appears to be normal. There's no intraocular tumor which is there. There's no intraocular mass which is there, right? So it's not retinoblastoma definitely. Please stay in the topic. I am asking you differential diagnosis of a lesion at the orbital apex. So I'll just move on. So this could be either infection, as I told you, anything, anywhere could be either congenital. If not congenital, then infectious, which could be or autoimmune, or it could be neoplastic. Okay. So similarly, you
Right.
can see infectious lesions here could be either tuberculosis, aspergillosis, herpes zoster, neoplastic, like these causes, okay, which have been labeled here. And autoimmune would be the orbital inflammatory pseudotumors or shock stress syndrome. So based on these differentials, we advise some investigations to the patient, which included a complete blood count, a peripheral smear, which showed hemoglobin to be 9.9. Hemoglobin electrophoresis was normal, and chest X-ray showed hilar prominence. Gastric aspirate was negative. CSF study was normal. So based on this, we had serum LDH levels and Montauk test, which was positive. And this was the finding in ultrasound abdomen. We advised ultrasound abdomen because we had these differentials in our mind. And ultrasound abdomen here showed multiple splenic abscesses. And FNAC was done from those splenic abscess, and the patient later was proven to be tubercular, to have a case, to be a case of multi-drug resistant extrapulmonary tuberculosis. And the picture which I had shown you before was a case of tubercular optic neuritis eventually. So nice try from your side. Tubercular optic neuritis is usually have a large variations in their clinical presentation, and high suspicion is usually required in patients of developing countries where tuberculosis is endemic, and most of the times it could be associated with tubercular meningitis. So this is the cause of diagnostic dilemma, like Gene Expert, which has a sensitivity of 97.83, so it has a good sensitivity. However, because of variations in their presentation, variable site of involvement, tubercular meningitis, and its associations, and it's being rare in children, always there is a dilemma in the diagnosis. So my purpose was presenting this case was to make you aware how to approach a patient who has an optic atrophy in one eye and this edema in the other eye. Okay, LHON patients in the initial stages, they might have telangiectasia, which might give you an appearance of edema. But actually it's not edema, they are telangiectatic vessels. In that scenario, family history is usually positive. A space occupying lesion can also lead to this scenario, but then that should be ruled out by imaging. And then demyelinating disorders, again with imaging and other investigations like CSF analysis can help you to actually reach up to the final diagnosis. And infectious etiologies could be again ruled out with imaging and targeted investigations for the suspected cause. So now our next case, moving to our next case, is of a 75-year-old female patient who presented with sudden onset diminution of vision in the left eye since 3 days, and there was no similar past history. But this, so I would just like you to read the history again. She's a 75-year-old female patient. Okay,
Right, ma'am.
and she
Right, ma'am.
and she presents with sudden onset diminution of vision.
Mhm.
She had a history of aortic dissection and ventricular dysfunction. Okay, she's a known
Right.
case of hypertension and she is on antihypertensive medications. Okay, she does not have any history of prolonged fevers or jaw claudication, rashes, or joint pains. And her general examination overall is normal and there are no other significant findings. So this is the ocular examination. Her left eye vision within 3 days has dropped to PL positive and PR was inaccurate. Okay.
Right,
And
ma'am.
other anterior segment findings were normal, although she did had a cataract in one eye. And fundus, you can see that, I'll just show the image of the fundus. You can see in the left eye, there was this margin with a temporal pallor. But there was hemorrhages, there are no cotton wool spots. This is the left eye fundus picture, which you can see that there is a temporal pallor. It's with blood margins and it's not very clear image because of the cataract.
Cataract.
And yeah, and in the right eye, you can see that the patient has a temporal pallor with reduced number of capillaries on the disc surface, and there are irregular margins too. Okay. So based on this, we advise certain investigations. So I would like you to tell what are the investigations which you advise in each neuro-ophthalmic patient who is having this kind of presentation.
And first of all, we will go for fundus photograph, OCT.
Before OCT,
Visual field means we would go to we must check for visual field defects.
okay, so can you please tell us what would be the visual field defects in different pathologies? In optic neuritis, which type of visual field defect do you expect? And what
Ma'am,
type
there might be central scotoma and there
central scotoma? What other scotomas can you find? Okay. So you can also have a centrocecal scotoma in optic neuritis cases.
Yeah.
If you read about the ONTT study, they had found that patients could have central scotoma or centrocecal scotoma or just a cecal scotoma. So in some cases. Okay. So, and what kind of field effect do you expect in case of papilledema?
Ma'am, it's central scotoma only.
No, it's not a central scotoma.
Means double arcuate type.
See, if it's a disc edema, disc is actually a blind spot, and if it's a disc edema, definitely there'll be an enlargement of the blind spot. Okay.
Right, ma'am.
In papilledema, you usually have this finding of enlarged blind spot. What kind of finding do you find in what kind of visual field do you find in a ischemic optic neuropathy? You have altitudinal field effects in patients with ischemic optic neuropathy. Okay.
Right,
And
ma'am.
other investigations which you usually advise when the in a neuro-ophthalmic patient are color vision and contrast sensitivity, which are usually compromised, which are actually the function of the optic nerve. And these are all the optic nerve function tests. Okay. So color vision we advise in this patient. So she was having a deranged color vision. Her contrast sensitivity was done. We did it with Perry-Robson chart. Can you tell other charts for contrast sensitivity?
I have only idea of perioption.
Okay, so there are other grading charts and Bistec chart, which is also used. We advise laser interferometry also if to just differentiate whether the patient had vision loss because of cataract or whether because of it was due to some fundus pathology. So we found that in the left eye, the fringes were not appreciated. That means that it was not just because of cataract her vision was low, it was also because of the fundus pathology. Okay.
Right.
And can you tell me an alternative of laser interferometry? If you do not have a laser interferometer, there is another instrument which is used for such a purpose. It's a
I have no idea.
It has a potential acuity meter is also used. Also has a similar use. It projects the visual acuity, Snellen's visual acuity chart in an inverted manner, which projects in a which forms an erect image in the patient's macula. Okay, so if you don't have laser interferometry, a potential acuity meter can also be used. So in this patient, Goldman's visual field were advised because of her vision. If patients who are having vision less than 618, usually Goldman's visual field are more commonly done in our center. And you can see in the right eye, it appears to be normal. And in the left eye, you can see that there was a longitudinal defect in this patient. So I have given you enough hints to tell me what this patient had.
It is a ischemic type of optic neuropathy.
So once we are clear that it's an ischemic optic neuropathy, then ischemic optic neuropathy has how many types? The ischemic optic neuropathy can be arthritic or it could be
non-arthritic and arthritic.
So, and it could also, this is anterior ischemic optic neuropathy. Okay. We
Right,
also have posterior ischemic optic neuropathy, which can again be divided into arthritic and non-arthritic. So, how will you differentiate between arthritic and non-arthritic type?
In the arthritic type, the main cause is it due to giant cell arthritis. Means it is because of giant cell arthritis, and in non-arthritic, it could be caused by any occlusion or at short posterior ciliary artery level.
Yes, very nice. So the causes of non-ischemic optic neuropathy usually includes like patients who are hypertensive, having atherosclerosis, or patients who have a sudden hypotension. Patients who are taking hypertensive medicine at the night time, usually they are at a higher risk to develop this non-arthritic ischemic optic neuropathy. Okay, that's because of the sudden hypotension and decrease in the blood supply to the optic nerve head taking place at those night hours. Okay,
Right.
uh, so what investigations will you order to differentiate between these two?
And we can go for means some blood test like lipid profile in we can go for, and
Okay. So an arthritic ischemic optic neuropathy characteristically has an increase in the levels of ESR and CRP levels.
yes, ESR.
So we did advise this patient all those investigations, and we advised her on to chest X-ray because as I told you that tuberculosis is an important cause. You always have to rule out that, and also because most of this neuro-ophthalmic cases they do require a course of steroids and immunosuppressants. We need to first rule out tuberculosis. For that, chest X-ray and Montu was done, which was normal. ESR and CRP, they were both raised. P-ANCA levels were normal, C-ANCA levels were normal. That rules out vasculitis as a cause of non-arthritic ischemic optic neuropathy. Patient was a known case of hypertension, but her blood pressure was controlled. And on inquiring about her drug use, she was not taking any nighttime medications. Okay. So
Right, ma'am.
based on that her ESR and CRP levels were raised, we moved on to a diagnosis of arthritic ischemic optic neuropathy. Although there were some of the things which were against, like the patient's temporal artery was not palpable and she was not having any jaw claudication, but raised ESR and CRP levels cannot be neglected in this case. Okay. So we had 4 differentials like atypical optic neuritis, anterior arthritic ischemic optic neuropathy, non-arthritic ischemic optic neuropathy, and posterior ischemic optic neuropathy. Posterior ischemic optic neuropathy usually takes place in patients who are having prolonged bed rest, or patient who had a prolonged surgery of spinal cord or of the central nervous system. It's usually seen in those patients. Okay. So differentiating this patient with atypical optic neuritis usually occurs in children or in adults more than 50 years. Our patient's age was more than 50, but usually these have bilateral vision loss, which was also there in our patient. Pain on eye movements was also there on our patient, but atypical optic neuritis, as discussed in the previous lecture also, they have severe hemorrhages, swelling in the disc, with MRI showing enhancement of the optic nerve, which was not there in our case. Okay, and ESR and CRP levels were raised, and atypical optic neuritis patients usually they deteriorate after steroids are discontinued. Okay.
Right, ma'am.
This is the fundus picture of a case of atypical optic neuritis on your right side. And in the left side is the fundus picture of a patient of atypical optic neuritis. On the left side, you can see that there is a fundus picture of our patient who was diagnosed as arthritic ischemic.
Arthritic.
So you can see the typical disc pallor in this patient is a pallid disc pallor. Okay.
Right, ma'am.
So if the patient has blurred disc margins, there will be some amount of pallor which is there, unlike the atypical optic neuritis patient. Now, these are the features which were there in our patient. And if you look here, so this is the, now how did we differentiate as I told you? So this is a picture, a typical clinical picture of a patient of non-arthritic ischemic optic neuropathy. Again, you can see patients who are having small disc, and these are the patients who are at risk. So this is known as disc at risk. Okay. And you can see the hemorrhages and the look of the disc. So that is the typical clinical picture of NAION, and this was the picture of our patient. So then if you look, I already told you about PION, right?
Yes, ma'am.
Other features which help you to distinguish are fundus fluorescence angiography, OCTA and OCTA. In fundus fluorescence angiography, you can see a delayed choroidal filling. The normal choroid fills in around 3 to 5 seconds. So, what are the typical diagnostic criteria for giant cell arteritis? Includes the age of more than 50 with a new onset headache, ESR more than 50, a palpable temporal artery. But it's not necessary that they'll be present in all the patients. Okay.
Right, ma'am.
It is evidence-based. In a study by Here et al., the mean age of patients was 50. The range of the age was 57 to 93. And visual loss of varying severity is always there. Patients might have features of amaurosis fugax as well as diplopia and eye pain. So, one common misconception is that it is always there. To diagnose giant cell arteritis, the patients must have symptoms and signs of GCA in the form of jaw claudication, but it's not so always. 21% patients of giant cell arteritis do not have any systemic signs and could have been a case of occult giant cell arteritis also. Okay.
Right, ma'am.
But my aim here was just to tell you that how an arthritic ischemic optic neuropathy looks like. Okay. So the management in these cases is to give patients IV methylprednisolone 1 gram per day, and our patient's vision also improved from light perception to finger counting. One important thing to always keep in mind when dealing with patients of arthritic ischemic optic neuropathy is to do a slow tapering of the steroids. So you do not hurry up to taper the steroids. They have to be tapered very slowly, but then one also has to judge because these steroids do have a large number of side effects, and common in this age group is osteoporosis. So there are other management options also like tocilizumab, monoclonal antibodies, okay, and methotrexate, which is another one. So, okay, always have an open mind and be flexible when you are dealing with optic nerve diseases. Take the history very, very carefully. Do not miss points. Do not skip systemic examination. That was the lesson which I learned in all these 3 cases. Because in our first case, the patient had hypertensive retinopathy. In the second case, the patient had splenic abscess. And in this third case, the patient had giant cell,
Giant
was
cell arthritis.
going towards giant cell arthritis, although at presentation she was not having anything like that. Okay. Always
Right.
do complete investigation and profile of the patient before you are planning for steroids. MRI is must because many a times patients might have some other things sitting behind which you can easily misdiagnose. Okay.
Right.
And differentiating between arthritic and non-arthritic can be based on the disc findings, ESR and CRP values. And always do remember anything in neuro-ophthalmology based on the age, do classify them as congenital. Again, I'll just repeat that. Could be the congenital, inflammation, tumor, trauma, or ischemia. Nothing other than this. These are the 5-6 causes which will be fitting, and you have to basically read about them because see optic neuritis you'll find in usually younger age patients, okay, unless it is an atypical optic neuritis. Ischemic optic neuropathies you'll find usually in an older age group of 40, and arthritic you'll find usually above 60 and 70 years. Okay, trauma will
Right.
have infinite history of trauma, which is usually in the forehead area. You might sometimes find that the patients do miss that and later present to you after years with a scar in their brow. That is again an important thing you should always look for. Toxic causes will have a history of a drug abuse in the form of alcohol or smoking or tobacco use, or they might, most common cause in our country is tuberculosis. So the ATT drugs like ethambutol and isoniazid do cause toxic optic neuropathy and are very common. Okay. To rule out
Right, ma'am.
tumor and a space occupying lesion, you need an imaging. And moreover, they usually present with bilateral disc edema. Okay. And in papilledema, the vision is usually preserved till the late stages unless optic atrophy ensues in. Okay. So that was all I wanted. These were all the 3 cases. Thank you.
That was an excellent talk, Gunjan. Really thank you for sharing such interesting cases. And I would also like to thank Praveen for making it quite interactive. Gunjan, we have a few questions for you. How do you tell the importance of temporal artery biopsy in GCA or to diagnose AION?
Yeah, so as I told you before also, that most of the cases of arthritic ischemic optic neuropathy will have a palpable temporal artery. It's only when the temporal artery is palpable you plan for a temporal artery biopsy in such cases. Okay. Otherwise, other non-invasive ways which are also coming in nowadays are the ultrasound Doppler, which can definitely show you the narrowing of the temporal artery and decreased blood flow through it. Moreover, an increased ESR and CRP levels are diagnostic for arthritic ischemic optic neuropathy. no second chance in that age group of more than 60 or 70 years.
I have one more question for you, which I have already covered. How do you treat tubercular optic neuritis once you have diagnosed it?
Yes. So for the case of tubercular optic neuritis, what is important is you need to coordinate with the physician. In our case, we took the help of a pediatrician who decided the drug doses and started the patient on anti-tubercular drugs. We did avoid ethambutol and isoniazid in our case. These two drugs, although they are anti-tubercular, they act as a double-edged sword because they, as I told you just now, that these are also at the same time they also cause a lot of toxic optic neuropathy also. So you have to be extremely cautious and careful when you are prescribing these drugs in these patients. And along with that, you also have to start the patient on steroids. The importance of starting steroids in these patients is that once you start anti-tubercular drugs, there is intense inflammation which takes place, which can further deteriorate the patient's conditions. So along with ATT, one has to start steroids and also supplement your ATT with vitamin B6 and multivitamins like B12, which will prevent toxic optic neuropathy, and that is what is being done.
Right. Thank you for answering the questions. So I hope the session was quite interesting because of the obvious masterclass and interesting cases by Dr. Gunjan. So any other questions can be mailed to Dr. Gunjan or to me. So we'll leave the session. Thanks for your patience.
Thank you.
See you on next Wednesday.